welcome to this explainer. Okay, today we're diving into a genuinely fascinating medical mystery. Have you ever looked up medical advice for a specific condition, expecting a clear, unified answer from the experts, only to find that the top professional organizations completely disagree with each other? Well, it happens way more often than you might think, and it's especially prevalent in the world of probiotics. So we're going to look at exactly why top medical organizations give such conflicting advice on probiotics, and more importantly, how you can actually make sense of it all.
And that brings us right to our central question. Why do expert medical guidelines on probiotics contradict each other? I mean, this can be incredibly frustrating, right? It totally agitates the confusion felt by practitioners and patients alike when the science seems to literally disagree with itself. You have these major, highly respected gastrointestinal societies reviewing the exact same body of research, yet they end up publishing totally different recommendations. It leaves doctors scratching their heads and patients wondering who they should even trust. But as we're about to see, this actually isn't a failure of science, it's just a predictable part of how medical guidelines are built.
All right, let's take a quick look at our roadmap for solving this mystery step by step. We'll start with the guideline paradox, then move into strains and evidence synthesis, followed by subjectivity in the grade framework. After that, we'll look at a real-world case study between the AGA and ESPGN, figure out how to navigate conditional recommendations, and wrap up with how we can improve future research.
Okay, starting right off with Section 1, the Probiotic Guideline Paradox.
We really need to establish right out of the gate that guideline discordance is a totally predictable reality. It is not some random failure of evidence-based medicine. As the source literature perfectly puts it, clinical practice guidelines are not simply numerical products of statistical algorithms. They are constructed using value judgments, predefined thresholds for uncertainty, and structured interpretation. I really want to emphasize that human elements are heavily magnified in probiotic research. Why? Well, because the effect sizes of probiotics are often pretty modest, and the data itself is highly heterogeneous, meaning it's cobbled together from a wide variety of different study types. So when the data isn't perfectly crystal clear, those human value judgments absolutely become the deciding factor in a guideline.
Moving right along to Section 2, Strains and Evidence Synthesis.
So the first real clue in our mystery lies in how researchers actually group this data together. We often talk about probiotics as if they're just one single thing, but treating them as a single intervention is literally like comparing apples to orangutans. Probiotic products vary widely by genus, species, and strain. They have totally distinct biological properties. Lumping all probiotics together into a single treatment group in a study is a huge risk because it obscures real, biologically meaningful differences. And when you do that, you naturally increase the risk of false negative and false positive findings, which directly feeds into these inconsistent guidelines we're seeing.
Which leads us to how researchers synthesize all this evidence. Since only a small number of studies are actually performed on each individual probiotic strain, how you combine the data matters immensely. Basically, a pairwise meta-analysis compares treatments directly, head-to-head, usually a specific probiotic against a placebo. But alternatively, you have a network meta-analysis, which combines direct and indirect evidence. Because every randomized controlled trial has some kind of comparison group, researchers can build a whole network to estimate how distinct treatments compare with one another, even if they've never been tested head-to-head. As you can imagine, different guideline panels choose different combinations of these analytical approaches, which naturally leads them to totally different conclusions.
All right, let's hit Section 3, Subjectivity in the Grade.
So grade is basically the gold standard framework experts use to rate the certainty of evidence into 4 distinct buckets. High means they're very confident the true effect lies close to their estimate. Moderate means they're moderately confident, but it could be substantially different. Low means confidence is pretty limited, and very low means they have almost no confidence in the effect estimate. Panels have to categorize the evidence into one of these 4 buckets before they can formulate any kind of recommendation.
But, here is the catch. While the grade framework is great for transparency, it absolutely does not eliminate subjectivity. You have the objective gathering of trials on one side, sure, but on the other side, these panels have to make subjective human judgments. They have to decide if they should downgrade the evidence for things like imprecision or heterogeneity. They have to interpret the clinical importance of really small effects. They have to weigh safety concerns when the data is super limited. So, you can have different expert groups applying the exact same grade framework to the exact same evidence, and they will reach completely opposite conclusions just based on these subjective judgment calls.
Let's put this into perspective with Section 4, a real-world case study, the AGA versus ESPGHAN. This brings us to a literal, real-world showdown. When the American Gastroenterological Association, the AGA, and their European counterpart, ESPGHAN, reviewed similar evidence, they literally never agreed completely on a single gastrointestinal condition evaluated. Seriously. For example, for children with acute gastroenteritis, the AGA made a conditional recommendation against using probiotics. ESPGHAN, on the flip side, made a conditional recommendation for using one of 4 specific probiotic treatments. Same data universe, totally opposite advice. Crazy, right?
So how in the world do they split like this? Well, it comes down to specific methodological clues. Guideline panels just apply different thresholds for including evidence. ESPGHAN required at least 2 randomized controlled trials testing a probiotic for a given condition. The AGA, meanwhile, completely excluded all open-label studies. On top of that, geography played a massive role here. The AGA naturally placed increased weight on evidence generated in North America, where most of its members actually practice. ESPGHAN obviously has a European focus. And this is particularly crucial for something like acute gastroenteritis, because the infectious etiologies, the actual bugs causing the illness, vary heavily depending on what part of the globe you're in.
And here's another wild split, this time regarding preterm and low birth weight infants. The AGA looked really broadly at 6 different outcomes: all-cause mortality, necrotizing enterocolitis, culture-proven sepsis, feed intolerance, days to reach full feed, and days of hospitalization. ESPGHAN, however, focused strictly on just one single outcome, the prevention of necrotizing enterocolitis. Because the AGA evaluated this wider range of outcomes and considered strains that could prevent any of those comorbidities, their panel issued completely different certainty ratings and recommendations compared to ESPGHAN's highly targeted review. Which brings us to Section 5, Navigating Conditional Recommendations.
So what are clinicians and patients actually supposed to do with all this seemingly conflicting information? Well, it really helps to understand that medical guidelines generally issue either strong or conditional recommendations. A strong recommendation means the experts have high confidence that the benefits clearly outweigh the harms, or vice versa. In everyday practice, this basically means do it or avoid it. Most patients should just follow it routinely. But a conditional recommendation, that highlights uncertainty. It means the benefits probably outweigh the harms, but different choices might be entirely appropriate for different patients.
So the real takeaway here is that a conditional recommendation, whether it is for or against a treatment, is actually an invitation to discuss. It places a huge emphasis on shared decision-making. Going back to our case study on acute gastroenteritis, both the AGA's conditional recommendation against probiotics and ESPGHAN's conditional recommendation for specific strains require the exact same clinical action. The doctor needs to sit down with the patient, discuss the uncertainties, the safety considerations, the cost, and most importantly, the patient's own values to make a shared decision.
Finally, let's look ahead. Section 6, Improving Future Probiotic Research.
How can the scientific community actually fix these issues and build more consistent guidelines in the future? Well, the field needs a few key solutions. To start, we need to be prioritizing patient-reported outcome measures, or PROMs. Basically, we need outcomes that genuinely matter to patients, like actually feeling better rather than just seeing a positive shift in some lab biomarker. Next up is strong external validity. A probiotic proven to prevent diarrhea in rural India might not be effective at all for a hospitalized patient in Italy. The study populations absolutely must reflect intended real-world practice. We also desperately need transparent adverse event reporting. It's often falsely assumed that probiotics are just inherently safe, yet one recent analysis found that 16 out of 35 studies provided 0 adverse event data. We need transparency. And finally, funding larger sample sizes. Way too many probiotic studies are small, fail to reach statistical significance, and are just dismissed as ineffective. This leads to type 2 errors, masking potentially meaningful effects that a larger study would have easily proven.
And honestly, we have to pump the brakes on the hype machine. The scientific ecosystem is vast, and there's this massive push for views and citations. To put that in perspective, a recent analysis found a staggering 1,400% increase in words representing hype in NIH-funded published abstracts between 1985 and 2020. Words like first of its kind or transformative. Researchers and media outlets really need to engage in responsible communication, avoiding extreme language and honestly conveying actual effect sizes so that guidelines can be built on sober facts, not exaggerated press releases.
So that leaves us with a pretty provocative question. If disagreement among guidelines isn't a failure, but rather a consequence of fragmented data and human judgment, then guidelines are clearly not definitive laws. They are just decision support tools. So, if clinical guidelines are just support tools, who really makes the final call for your health? You do, in partnership with your doctor. Understanding how these guidelines are made empowers you to take charge of your own shared medical decisions. Thanks so much for joining me on this explainer, and keep asking the right questions.